So I'm excited to be here. Thanks for the opportunity and the invitation to participate in this event. I think anytime we get a chance to talk about this issue of obesity and how it's impacting our patients, our family, our friends, and what we can do about it, I think is really important. And I think Dr. Lustig gave a really passionate discussion about, informed discussion about a lot of these issues that, really underscore the fact that obesity is a complex disease, right? What he described is a really sort of complex etiology of disease, and your exposure to these obesogens, your exposure to the environment may vary. Some of our, patients and some of the issues that they deal with related to obesity may be very different in terms of, I've got patients who've had hypothalamic obesity, who have hypothalamic obesity simply because they had a procedure to fix one problem and then developed another problem. And then I've got patients who, sort of in a very ironic twist, deal with food insecurity, but still have obesity, right? So only in this country can we do that, right? Can we combine the lack of food with an excess in body weight? So what I'm going to do, what I've been asked to do is talk about the science related to evidence around obesity treatment to reduce the risk of type 2 diabetes and cardiovascular medicine or cardiovascular disease. And I'm going to try to focus in on a few different things. Here are my disclosures. I work with a lot of the friends of Dr. Lustig. The objectives are really, I'm going to try to do similarly, set the stage in terms of the disease state. I'm going to come at it from a slightly different way, but you'll see some themes. And then I'm going to talk in two different sections about diabetes, both prevention of diabetes and the treatment of diabetes with regard to the idea of remission. And then I'm going to pivot and talk about cardiovascular disease risk and outcomes. And we've got some really exciting data in this area related to metabolic and bariatric surgery, as well as GLP-1 receptor agonists. So let's start out with a quick case. You may have seen a patient like this. This is someone from my clinic, 52-year-old male, comes in for evaluation and treatment in our weight management program, and he's got a history of recently type 2 diabetes, hypertension, hyperlipidemia. And his current history shows that over time he's gained about 10% of his body weight. And this is something I always encourage audiences in the healthcare space. Do a quick scan of the patient's weight. One of the leading indicators of obesity is the fact that people are gaining weight abnormally, right? Most people are not gaining weight on purpose. I've not had one patient who came to me and said, I tried to put on 50 pounds. It's usually I put on 2 or 3 pounds a year for the past several years, right? That small imperceptible weight gain that I just, I had an extra loop in my, buckle in my belt, so I just let it out this year. And then that leads to what we then diagnose as obesity, but we've seen the evidence of positive energy balance happening all along. So we should be shifting our focus much, much earlier in the disease state. Off the soapbox. Lab assessment shows elevated AST, ALT, maybe some evidence of fatty liver. We know he's got diabetes with the A1C that's elevated. Triglycerides, LDL are also elevated. Clearly has metabolic syndrome. And the patient is interested in losing weight to improve quality of life and medical conditions. And he says, well, I used to be healthy. How did I get to this point where I have all these medical issues, right? I turned 50 and my life, my health falls apart, starts to fall apart. Well, it's not by happenstance. It's not by happenstance. And so we know that obesity has an impact on pretty much every system in the body and globally impacts quality of life. We're going to focus in on cardiovascular disease and dysglycemia for this evening, but the idea still stands that all the things that we're going to talk about from a fundamental principle, even when you think about osteoarthritis, the things that we're going to talk about in terms of inflammation, insulin, those things are having an impact at the joint. It's not all just about the number of pounds that people are carrying and the gravity, impact of gravity on those joints. So the primary insult, as you've heard Dr. Lustig talk about, is really a combination of a number of complex things, but really gets into the idea that you have overload of the adipose storage system. And once that happens, you've got insulin increasing, as he described, and you start to then liberate, or you start to increase circulating factors that then result in deposition of ectopic fat. You have to put that fat somewhere. And the body can only store so much in the safe place for storage, which is in your subcutaneous storage space, right? We're meant to store and easily access fat under the skin in that sub-Q space. Once we fill that space up, then it's got to go somewhere, especially if we're not accessing that, not using it in the moment. So where does it go? Well, it spills over into the organs. And insulin resistance is really a key part of what moves all of that process along. And so I won't get into all of that because Dr. Lustig so beautifully described all of the downstream impacts of increasing insulin that then supports that anabolic state and then leads to all of the complications of obesity that we end up treating. So here's just a picture to help you understand what we're talking about when we say we're filling up those sub-Q spaces as shown here in the blue. That's the fat under the skin. And once those areas are filled, then you spill over into that ectopic fat deposition. And that becomes disruptive because your organs are not meant to store fat. And so what happens when you start to store fat in the visceral adipose space? Well, what you end up doing is attracting macrophages, and those macrophages set up shop, and they start to interact with the fat cells to increase. They start to interact with fat cells to increase the amount of circulating inflammatory markers. So your cytokines increase, adipokines increase. And so you had now an inflammatory milieu that is being generated as a result of having that excess fat being stored in a tissue depot that it shouldn't be there. And so now you've probably heard of this model that starts to tie a lot of these organ dysfunction, or a lot of this organ dysfunction together, but starts out fundamentally with the issue of excess fat deposition. And that then leads to that metabolic risk that's increased, the atherosclerotic disease, the renal disease that then comes on top of that, the dysglycemia, all of those things are now being related, including excess fat in the liver and metabolic associated steatohepatitis. So now we're starting to really start to fundamentally understand, while we've been treating all of these diseases in a silo and thinking about them from a endocrinology standpoint, or thinking about it from a GI liver standpoint, or thinking about it from a kidney standpoint, from a cardiovascular standpoint, really what we were doing is just trying to keep the water from going over the dam because we weren't treating obesity. We weren't treating the fundamental cause of all of this dysfunction. And so now we're at a point where I think, okay, we actually understand this biology better. We have tools that we can use to successfully treat the underlying problem. And we're starting to get data that shows that not only are we able to control disease and limit the damage of end organ, these chronic diseases at the end organ level, we can actually get to remission of disease and get back to a normal, healthy state where we're reducing that burden of the excess adiposity in that the visceral adipose compartment. And so this is one example of how we started to shift our thinking, right? This comes from the ADA, American Diabetes Association, and you start to see that aside from the idea that, okay, well, we want to put the patient in the center, which is great. We're finally deciding that's a good thing to do. And then, but we're dedicating weight management as a real cornerstone of the treatment paradigm, and starting to understand that, if that is a driving factor for the chronic disease that the patient is dealing with, we're obligated to, I would argue, we're obligated to help the patient understand that and get to a better health state through treatment of obesity. We also know that with differing amounts of weight loss, we start to have impacts at different levels for different organ systems. And the reason this is really important is because historically, what we've been trying to do is consistently get above 5% weight reduction. That's our guidance to get something approved or to determine that it's effective as a weight reduction strategy. But we're also starting to recognize that the larger volume weight loss will be beneficial for the patient, especially when it comes to things like blood pressure, where you start to see a fairly consistent drop in blood pressure with greater weight loss. Dyslipidemia, hyperglycemia. So trying to get people to remission for type 2 diabetes, you're trying to get that target at 10 to 15% weight loss at least. Double-digit weight loss is now really where the money is in terms of dealing with a lot of the chronic established conditions that are downstream impacts of obesity. If you're talking about prevention of type 2 diabetes or prevention of going from prediabetes to type 2 diabetes, elevated blood pressure, preventing that from increasing, certainly 5% will get you there. 3% may even be useful in those cases. But a lot of our patients already have a lot of established issues. And so we want to be able to effectively address that. And so we're talking to our patients about the idea that obesity is driving a lot of these problems, and we want to effectively deal with the driver of the problems. Then that means that we have to now offer treatment that will actually get the results that we're talking about. So what is the evidence that we have that we can do this? And where are we in terms of, evolution of treatment? So I'm going to review some data that are a little bit older just as a way to help us understand where we are. But, a lot of these data are, good data that help us understand across a spectrum of different treatments. We have a lot of options. We have a lot of options for our patients, and a lot of the treatments that we have can be very effective for a particular target of treatment. So let's start out with prevention of type 2 diabetes. We've got a lot of data in this space from classic, randomized controlled trials that look at large populations and follow them over time. We have the Daking study from China in the late 90s that followed people and looked at, prevention of type 2 diabetes using a lifestyle intervention that was comprehensive in nature. And what you see is a 51% reduction in progression to type 2 diabetes at 6 years and over 40% reduction over 20 years. We have the Finnish diabetes prevention study, which also showed very similar treatment effects over a similar point of time, 6 to 13 years. And then we have here in the U.S. the classic sort of diabetes prevention study, which again compared lifestyle intervention to metformin and showed a benefit greater for lifestyle intervention compared to metformin when it comes to preventing the conversion from prediabetes to type 2 diabetes. And you see that effect is sustained over 10 years with 34% of reduction in the progression to type 2 diabetes. When it comes to thinking about cardiovascular outcomes, we know that from the Look Ahead study, that trial was stopped early because it was negative. It did not show any benefit in people who had type 2 diabetes using a lifestyle intervention to actually try to prevent excess cardiovascular risk or events. When you look at a sub-analysis of that trial, one of the things you find is that people who were able to achieve that 10% weight reduction actually did see some benefit in terms of reduction of cardiovascular events. So that subgroup who was able to achieve that double-digit weight reduction on average actually did see a benefit in terms of cardiovascular risk reduction with lifestyle intervention. And then we have the DIRECT trial, which is a study that actually targeted diabetes remission as a goal. And by diabetes remission, what we're talking about is someone who's been able to maintain their A1C below 6.5 off medication for at least 3 months. And in the DIRECT trial done in the UK through primary care offices, they were able to show that an average weight reduction of about 10 kilograms over a 1-year period led to significant reduction in A1C, and the number of people who were able to achieve remission of type 2 diabetes in the first year was right around 46%, and you see that that was sustained through the second year of follow-up at 36%, compared to control that was only 3% reduction in terms of remission of type 2 diabetes. So again, a lot of our patients who have type 2 diabetes, to me, these data suggest that either they don't have to have type 2 diabetes. With the right type of lifestyle intervention, they can be successful with achieving remission. And if you have patients who have prediabetes, a lifestyle intervention, comprehensive lifestyle intervention, can be successful in terms of helping them to reduce their risk of developing type 2 diabetes. And by the way, these are very cost-effective. These are very cost-effective interventions. It would be great if we as a system, as a healthcare system, invested more in engaging people in these types of interventions, combined with doing environmental level interventions to really help people move the needle when it comes to health status and risk. When we think about the impact of bariatric surgery on type 2 diabetes, now we're talking about an even more powerful intervention because, in my opinion, a lot of that impact is really related to the fact that we're seeing a significant reduction in excess fat. We're seeing a significant reduction in that visceral adipose tissue compartment. And so you can see here by different types of surgery going from gastric banding to BPD, a duodenal switch, as the percentage of weight loss tends to go up as we go down that scale, you start to see higher proportions of individuals who achieve remission of type 2 diabetes. And the average or the median disease-free period of time following a Roux-en-Y gastric bypass for an individual with type 2 diabetes is about 8.3 years in one particular study, one particular cohort. And the predictor of response was younger age, shorter duration of diabetes, so less than 8 years, if they're not on exogenous insulin, and if they achieve greater weight loss. All of those things predict a greater treatment response. So to me, this suggests that we should be getting to people earlier. We should be talking about metabolic and bariatric surgery as a treatment for diabetes. If our patients have diabetes, and we shouldn't wait for it to be so poorly controlled that they have to be on insulin in order for us to offer metabolic and bariatric surgery as a treatment. So we're going to give them a better chance of being disease-free because there are plenty of data that suggests even having well-controlled type 2 diabetes is not as good as not having diabetes from a cardiovascular health standpoint. So we can't accept or be okay with the idea that our patient panel has an average A1C of less than 7. We have to think about at the individual level, those patients are going to have benefit of actually seeing a lower A1C and not having dysglycemia. I'll finish up talking about diabetes and bariatric surgery with the ARMS 2D study, which is a really interesting combination of clinical trials in bariatric surgery that have now pooled their data. You can see the 4 studies that have participated or contributed patients to the follow-up. And in this ARMS 2D study, they followed people now for over 12 years. And what you see is that on average, individuals who've had bariatric surgery have a lower hemoglobin A1C, and they achieve greater weight loss over time and sustain that weight loss over time. So you're looking at about a 20% reduction almost in terms of body weight out 12 years. And you see a significant reduction in hemoglobin A1C. And by the way, 25% of the medical group actually converted over to bariatric surgery. So even with a quarter of the people in the medical treatment arm converting over to bariatric surgery, you still see a benefit for bariatric surgery group from the initial randomization. Here's some other data from that ARMS 2D study paper that show you have a pretty significant reduction in number of people who have type 2 diabetes in terms of remission with bariatric surgery. That tends to tail off over time, and that may be because some people are now taking medications, right? So definition of remission is that you're not taking an anti-hyperglycemic, and you can see over time, though, that the use of medication for the surgery group in the blue bars is still lower than for the medical group in the red bars. Now let's switch to finish up and talk about cardiovascular outcomes. So with bariatric surgery, we've got plenty of data that show and have shown over a long period of time the association between bariatric surgery and a reduction in cardiovascular events. And these are very robust in terms of decrease in the risk of mortality being about 37%, reduction of new onset heart failure being over 50%, reduction in MI or stroke also being very significant. And that's been demonstrated in a number of different cohorts. I've just got two examples here that show a number of different outcomes, but as compared to matched controls who are getting good medical therapy, when you see the use of bariatric surgery, you see the impact, the difference that it makes on those curves. And look at that separation in those curves. It's happening very early. It's not a delayed effect. So to me, that suggests it's not just about the weight. It's not about the total body weight. It's about the internal environment. Once you start to implement a negative energy balance, you have a very dramatic impact on the internal milieu in terms of that inflammatory milieu, in terms of all those cytokines, in terms of the insulin levels, insulin sensitivity and resistance. All of that improves very quickly. And that may be driving a lot of these early differences in those curves. Had to get to semaglutide eventually. So here we are, semaglutide in the SELECT trial. I think this is one of the most interesting developments in the space of obesity in recent time. We're talking about, for semaglutide, 2.4 milligrams weekly in individuals who have pre-existing cardiovascular disease and overweight or obesity, but not type 2 diabetes, 3-point MACE as the outcome. And what you see here is a 20% reduction in the primary endpoint of that composite cardiovascular outcome. When they went further to try to understand what was driving that, you hit that first stopping point because they were looking at death from cardiovascular causes. It was not statistically significant, but subsequent analysis show that, yes, there are some differences in terms of other cardiac events that may be contributing to driving that endpoint in a different direction. But this is the first time that we've shown with a medical therapy designed for the treatment of obesity that we can see a reduction in hard outcomes from a cardiovascular standpoint. So this is landmark. And now we also have STEP-HFpEF, which is, again, looking at semaglutide 2.4 in the setting of heart failure. And this is heart failure with preserved ejection fraction. And basically what you see here is that with the Kansas City Cardiomyopathy Questionnaire, that individuals show a significant improvement in their symptoms of heart failure, and that's associated with a significant weight reduction for individuals on treatment. And this shows you that they are also increasing their actual physical function as measured by a 6-minute walk test. So if I had to summarize, I feel like what I've tried to convince you of is that obesity is a primary driver of a lot of the health outcomes that we treat on a regular basis, including type 2 diabetes and cardiovascular disease. And if we understand that excess adiposity is the primary culprit, then it means that we will treat that as a chronic disease, as a part of a way to modify chronic diseases that come downstream. Obesity treatment can prevent type 2 diabetes. It can put type 2 diabetes into remission. Bariatric surgery does the same in terms of both lifestyle and bariatric surgery are effective, I should say. And bariatric surgery has a very clear association with reducing cardiovascular events. In several large observational studies, I didn't have time to go into all of that detail. And now we have data about semaglutide 2.4 leading to a reduction in cardiovascular events, as well as improving patient-reported outcomes with regard to heart failure. I appreciate the opportunity to be here.